So excited to have you all here today. We are here for many reasons, but one of them is because we have received a grant from the Administration for Community Living. Memory Lane Care Services and Summit County Public Health are here with you all today and have many collaborative partners. But we're able to present this to expand some education and training about IDD and dementia. So just some of the grant goals. Many of you have been involved in these projects, but are increasing your knowledge and skills of interacting with people who are living with IDD and dementia. And our speaker is going to talk a lot more in detail about why this is so important. We're just here to bring education to our communities and especially the IDD population. Um, as I mentioned, I'm with Memory Lane Care Services. My name is Lindy, but I also have many coworkers and panelists on the call today, as Lisa mentioned. We're here representing the Northwest Ohio area. And then Donna Barrett, would you like to say hello?
Hello, everyone. Thanks for attending.
And Donna is with also Summit County Public Health. So we have two grants across the state and have come together to offer these trainings. Have partnered with Lisa and Jen and many others in our local county boards of DD to offer this training today. So I just want to thank you all so much for being here. If you're ever interested in or in the area or even in Ohio want to learn more about other activities, please reach out. And today I would like to ask you to complete a survey. So there is a QR code on the screen. But for our project purposes, Miami University Scripps Gerontology Center and an evaluation team named Smile Minded SmartWorks have developed an evaluation for us today that you'll do now and then do at the end of the training to help us improve these trainings and help us improve services and supports for individuals living with IDD and dementia in your community. So you can either scan the QR code on the screen. I'm going to leave that up there. And then I'm also going to put a link in the chat. And then after that, we're going to give you just a moment or so, and then we're going to go ahead and introduce our wonderful speaker, Jennifer Pettis. So I put that link in the chat. It should not take more than a couple minutes, maybe 3 to 4 minutes at the most. Scan the QR code or go ahead and click the link in the chat. And then I'm going to introduce our speaker here in just a moment.
Thank, whoops.
Lindy, I'm not sure if the link is in the chat.
Let's see here. It
Yep,
should be went to everyone.
Yep.
Okay, it
I
did.
can put
Okay.
it to panels and hosts too if you're
Oh, I
interested.
see. Got it.
Yeah,
Thank
11,
you.
10 a.m. There you go. And make sure everybody, I try really hard. I always tell everybody I'm gonna cross-check my evals with Lindy's to see if she got her pre-test and her post-test. So
Perfect.
do your best to get that done. One person said the link's not working, so maybe put your screen back up just to see if they
I
can
will
try the
absolutely do
QR
that.
code.
And if maybe one of our speakers or panelists could check to make sure the link is working. And then I'm going to put it back up my screen for the QR code too.
I'm taking it now off the QR
Okay,
code.
perfect. Okay, well, at least the QR code works.
Oh, and Aunt Tapia said that it's working for her too, so we're good there.
Okay. Whoops.
Yeah, the
Sorry about
link
that.
worked for me as well.
Okay, thank you, Nikki.
All right, we're good.
Worked for me too.
All right, I'm going to give folks just a minute just to get that started, and it shouldn't take too much time. And then I'm going to introduce our speaker.
Just really want to give a shout out to we have 235 people on the call today, and I'm just so excited that Ohio is so passionate about this topic, and I really appreciate everybody coming on. And if you are not in the county board system and you're here because you heard about this through another way, we're so thankful that you're here also. So. All right.
Yeah, I don't know. I mean, if Some people, the link is working and sounds like so others are having issues. Maybe copy and pasting the link into another browser. I'm trying to think, or if you can try the QR code, I'll share that one more time and then we are going to go ahead and get started. So if it is not working for you, I would ask that you scan the QR code with your cell phone if you're familiar with doing that here on the corner screen. Okay. All right. Well, I hope that works for you all. I'm just really excited to get us started today. And as you are finishing and starting that evaluation, which we so much appreciate you doing, I'm going to go ahead and introduce our speaker today. So Jennifer Pettis is the Director of Strategic Alliances at the Gerontological Society of America. At GSA, Jen directs the development and production of strategic alliance programs to further the Society's mission and strategic goals. Her responsibilities include providing leadership to drive growth in new opportunities involving existing or potential new partnerships for the Society, developing and managing key relationships and alliances, and representing the Society at strategic partner meetings, professional conferences, and meetings with stakeholders. During her over 30-year career as a registered nurse, Jen's work has focused on improving the lives of older adults. She has provided direct care to older adults, led interdisciplinary care teams, educated others to improve care and services for older adults, and conducted health policy research and advocated for policies to enhance our lives as we all age. So that is our wonderful speaker today. And Jen, we just want to thank you so much for being here, and we would love to give the floor to you.
Thank you so much. And thanks for everyone that's joining us today. This is fantastic to have such a wonderful turnout. Really exciting. Hopefully you're seeing one big slide on the screen now. Lindy, are we good with seeing the screen?
Yes,
the
looks
slide?
great, Jen.
Okay, very good. Thanks. Alrighty, well, we'll go ahead and get started. As Lindy said, my name is Jen, and I welcome you all to use the chat today. We're going to talk a bit about how we're going to use that together. And remember that that Q&A tab is there for you to put the Q&As in. And hopefully we are recording, just double checking that. Okay. Okay, very good. All right, so we'll go ahead and get started here with some program objectives. Today we're going to look at normal signs of changes in our brain as we age, but then how do we compare and contrast those with someone who might have Alzheimer's or dementia? We're going to talk about promoting brain health. So whether it's for you or whether it's for the people that you work with, how can you make sure that your brain is as healthy as it potentially can be and give those tips to others? And then I'll share with you about this GSA KAER, K-A-E-R framework. We'll talk about the benefits of that framework and then talk about some tools and resources that are available in the online care toolkit. And then explore a resource that really does have roots in Ohio, and that is a care toolkit companion that supports people who are caring for individuals with intellectual and developmental disabilities. And I mentioned that that has roots in Ohio because two of the groups there in Ohio, including OACB and the Ohio Council for Cognitive Health, supported us in the development of that work. And throughout the program, I'm going to ask you all a question or two, and I'll ask that you use the chat, and I'm going to figure out how I can get it so I can see that chat. I'm going to get that over on my screen so I can see what you have to say. And then, so I'll ask you a question and ask that you go ahead and share your thoughts in the chat. And at any time, I invite you to use the chat to share ideas or comments that you have about the program as well. But I do hope you're all 200 and some of you are going to be ready to share your thoughts here. And so the first chat I want to pose to you right early in the program, and that's to ask you, how does your provider check your heart or your lungs? Last time you went to and had a physical or had a doctor's appointment, how did they check your heart or your lungs? And just chat in what you think there. They listened, they used a stethoscope, blood work, breath sounds, stethoscope. And now I want to ask, how did they check your brain? How do docs check or the providers check your brain? Somebody said with questions about cognition or a mini cog, assessments. Oh, somebody had full body scans, mental status. So is it routine that you get that mental status or cognitive check when you go to the doctor? Oh, you guys are really chatters. Wow. Typically don't ask about brain health. I saw that question. And we ask about depression, we ask about other things, but it's not so routine to check our brain. So how can we change that? So let's think about that. Why don't people routinely talk about brain health? Why don't doctors, when I say doctors, I mean doctors, nurse practitioners, providers in general. So why, or PAs, why don't providers, my doctor has never asked about my brain health. So why don't providers routinely talk about brain health? What do you think is the cause? Why do they not talk about this thing that is running our whole body? What do you think? Limited time, takes more time. They wait until patients are a certain age. Brain health is scary. It's understudied when it comes to dementia. They don't know how to do it. They don't know how to address it. Sometimes there's limited knowledge. It's more subjective, right? It's easy to listen to something, but to really find out how someone is thinking is harder sometimes. Someone mentioned they don't get paid for it. That's very often true. Often it isn't assessed until they get to Medicare, and that is true as well. Right, lots of great points you guys are making about there is somebody said there's a focus on symptoms to treat, not proactive approaches. So thinking about your role, whatever it might be in the community, whether you're caring for someone, providing direct care, more of a case manager, how do you help to normalize conversations around brain health and to promote those brain health conversations? What can you do? So what are some ideas how you could make a difference in moving the dial on having these conversations? Advocating, great. How about asking a provider, how do you usually check brain health? You do some dementia screening at annual exams. Ask an individual if they've sought counseling or what they're observing. Ask the doctor. So just asking about routine brain health checks. So checking our brain. Oh, somebody says bring out the care toolkit. Very good answer. All right, so we'll just talk more about it, right? Normalize these conversations. Somebody said advocate to remove the stigma or personal embarrassment. There's a lot of stigma around talking about dementia and brain health. And there's also this kind of idea of a lot of times folks just kind of attribute things to cognitive changes to I'm just getting of a certain age, it's normal. But it's really important to say, well, what is normal aging, typical age-related changes versus signs of dementia or Alzheimer's disease? So we all forget things. We all go downstairs. I go down to my storeroom to get something and come up with 3 other things and not the thing I went down there for. But then I get back up and I go, oh, shoot, I forgot to get that. That's a normal age-related change. But what's not normal is true memory loss, where we're forgetting things, particularly things that we recently learned. And we maybe are using a whole lot more sticky notes all over the place to remind ourselves of things. Or we're asking the same questions repeatedly. It's normal to need help to set up an appliance or set up a new electronic device. But what's not normal is having difficulty making our favorite recipes or remembering how to play a favorite game or doing really familiar tasks like making a grocery list. Everyone has made an occasional error in your household bills. The time you should have deducted something from the checkbook, but instead you added it in, but you figure it out and you go back and correct that. but it's not normal to have difficulty planning or problem solving with following a budget, not being able to maintain those bills at all, not following your recipes. It's easy to forget what day it is, particularly if you're on vacation. You're like, "Ooh, is today Wednesday or Thursday? I'm not sure," but you can remember it later. But if we're confused routinely to time and place, we kind of lose track of the season. We got somewhere and really don't remember how we got there. We forget our time or place. Those are not normal changes. For if we forget something and then we lose the ability to retrace those steps to find that, that would be an abnormal change. Versus if we were lost our keys and we said, "Okay, wait a minute, I had them last time I was in, this room," and then we can kind of retrack our steps and figure out where we found those. Then that would be a typical age-related change. And then again, with someone misplacing things and perhaps saying, "Well, someone else took them," versus you say, "Oh, I lost them. Let me go find them by retracing my steps." We also, as a typical age-related change, may sometimes forget which word to use. But if we had signs of dementia or Alzheimer's, we would be potentially unable to name familiar objects, have difficulty having a conversation, so really having problems with words or speaking. It's very common as we age to have visual changes, particularly losing our ability to see close up, which is why I'm sitting here wearing my computer glasses as I talk to you. But when folks have potential Alzheimer's or dementia, we may see really visual image changes and spatial relationships. I spent a lot of my career working in a nursing home, and I can remember residents with dementia like literally falling into their closet because they lost that kind of ability to see themselves in that spatial relationship. Or if a floor had black squares, tiles on it, with people really trying to step over that tile because it looked like a hole to them. Typical age-related changes for judgment might be we occasionally make a bad decision. We neglect to change the car oil for a bit too long. But changes in decreased or poor judgment for someone that may indicate signs of Alzheimer's or dementia are changes in grooming. Somebody who's usually very well groomed is wearing the same clothes for 3 days in a row, or their ability to manage money is really problematic. Perhaps they have really bad judgment about trusting people with money and things like that. Typical age-related changes for social activities. Sometimes you don't feel like attending a family or a social obligation. My husband has a shirt with a brown M&M on that says, "Sorry, I'm late. I didn't want to come." I always laugh about that shirt when I see this line. Whereas withdrawal from work or social activities, not being engaged in their favorite hobbies, maybe not dining out because it becomes overwhelming, that is something that really can show a sign of dementia or Alzheimer's. And then routines. As we get older, many of us become more fixed in our routine, and we become irritable when that routine is disrupted. That's different. That's a normal age-related change versus changes in mood or personality where we become suspicious, we're afraid of people, we're anxious around others. And I see we have a question about, is it true that if someone has hearing loss, that is an increases the likelihood of dementia, and that certainly is the case. And I apologize, I just see I was a slide behind on my slides. So again, those changes, the signs of dementia versus the typical age-related changes are there. But these two slides that I just shared with you are really about the general population. So we say, well, what's different? What if someone has Down syndrome and then has dementia along with that? It's important to remember that dementia and Down syndrome often appears earlier, commonly for someone in their 40s or 50s, and it presents differently than typical Alzheimer's disease. It is common to see personality changes, behavioral shifts, and executive dysfunction before the appearance of significant memory loss. So personality and behavior changes, I think, are really key issues here. Key unique early signs include reduced social interaction, apathy, new seizures, and a faster progression of losing functional daily skills. I think it's important that we talk about each of these unique early signs a bit more, and we'll kind of drill down to those on the next slide. Okay, so behavioral and personality changes. There's significant early changes, often include increased irritability, becoming more uncooperative, agitation, so maybe not being able to sit still, that behaviors where people may ask repeated questions or really have kind of pacing and restlessness. All of that kind of falls under that umbrella of agitation, or they might be aggressive. There might be social and emotional changes like reduction in conversational interest, increased apathy, or conversely, increased fearfulness and anxiety in new or familiar situations. Someone asked if we can get a copy of the slides. The slides will be shared with you, yes. Early functional decline, loss of skills and interest in activities, so grooming or job-related tasks, and significant decline in attention span. Physical or neurological changes include development of new seizures, what some people will call epilepsy, later in their life. So not something they've had for their lifelong, but they develop that later. Changes in mobility, such as increased clumsiness or difficulty walking. And unlike typical Alzheimer's and Down syndrome can have a much faster decline, including quicker loss of language and cognitive abilities. And think about cognition too as memory and thinking. We're not just thinking about memory loss, but really changes in how someone thinks. And then changes in some sensory function, the potential for increased sensory issues, including poor depth perception, that idea that I talked about where someone just has no idea of kind of where they are in space, and increased difficulties navigating, including around stairs. The good news is whether you are part of the general public, general population, whether you have an intellectual or if someone has an intellectual or developmental disability, there are things you can do for your brain and protecting your brain health. And that's, again, how we think, how we learn, how we remember is important at every age, at every stage of life. And so if we're building brain healthy habits now, whether we're helping the people we care for build them, or whether we're helping our family build them, whether we're raising our kids with brain healthy behaviors, it's important for everyone, including people with a history of dementia. And I want to mention that nothing that we're saying here is preventing dementia. What we're hoping we can do is help lower the risk of cognitive decline and possibly Alzheimer's and dementia. So things aren't preventative per se, but they help your risk reduction. So challenge your mind, be curious, put your brain to work and do something that's new for you. Learn a new skill, try something artistic, challenging your mind. So that can have long or short-term benefits for your brain. Staying in school, education reduces the risk of cognitive declines and dementia. Encouraging young people to stay in school and pursue the highest level of education and training possible. So take a class at a local library, get involved in a trade school, go to a college if someone has the opportunity to do so, or learn online. And get moving. It's so important to engage in regular exercise, and this includes activities that raise your heart rate and help your blood flow to your brain and your body. So move more, and that can mean formal exercise if that is what works for you, but it also means things like gardening and dancing and walking. Whatever works for you to get moving is a great idea. Protect your head. It sounds simple enough, but really preventing head injury, wearing a helmet for activities like biking, wearing a seatbelt, protecting yourself while playing sports, and doing what you can to prevent falls, especially for older adults. And being smoke-free, quitting smoking can help lower the risk of cognitive decline back to levels similar to those who have never smoked. It's truly for your brain, never too late to stop smoking. And then control your blood pressure. So healthy habits like eating right and physical activity, along with working with a healthcare provider if you need to take medications or other steps to control your blood pressure. And type 2 diabetes can be prevented or controlled by eating healthier, including with increasing physical activity and taking medication if needed. And then eating healthier. There's a lot of information out there about reducing your risk of cognitive decline through eating healthier foods. And this includes vegetables and fruits, leaner meats and protein, along with foods that are less processed and lower in fat. So choosing healthier meals and snacks that you will enjoy and that are available to you. The MIND diet, MIND, is one diet that is mentioned, and that really provides optimal nutrition for brain health. The MIND diet and other well-established diets like the Mediterranean diet or the DASH diet share some common themes. These give you the healthy meals and snacks that by incorporating more fruits and vegetables, swapping healthier cooking oil, again, fruits and veggies, lean proteins, lower fat foods, healthy whole grains, healthy fats, and limiting saturated fats and highly processed food. And then maintain a healthy weight. Again, work with a healthcare provider about the weight that's healthy for you, and other healthy habits that we've talked about here, like eating right, exercising, and sleeping well, can help you maintain a healthy weight. And then finally, sleep. I can't say enough about good quality sleep. Trying to, and I'm a healthcare provider, as all of you are providers of care. We know that it's busy and it's very easy to put everybody else's rest and well-being ahead of you, but it really is important to try to stay off screens before bed, make your sleeping space as comfortable as you can, minimize disruptions, and certainly if you have sleep-related problems like sleep apnea, talk with a healthcare provider. So I have a few questions for you all now. And that is, how can you challenge your mind? Let's give a few ideas about how you can challenge your mind to help keep your brain and your mind active. So take a minute and put in the chat how you can challenge your mind. We have reading, puzzle books, learning new hobby, board games, go somewhere new, do a new activity, Sudoku, learning a new skill, brain games, meditation, knitting, daily walks, chess. Oh, chess is tough. Learning new crocheting patterns. So just learning new things. It's all about reading, word games, bird watching, learning new birds. That's a great one. So yes, staying busy, keeping your mind busy, and engaging with others, talking with other people for sure. So the MIND diet, I mentioned that. What kind of food should we prioritize in our diets to promote brain health? Veggies. Oh, somebody mentioned more in a foreign language, a few people. Superfoods, vegetables, fish, fruits, walnuts, omega-3 fatty acids, whole grains. You guys are great. Green leafy veggies. Excellent. And then whole food, unprocessed food, salmon, water, someone mentioned, fruits and avocado. I love it. All right, supplements. Somebody mentioned supplements, and because we mentioned that, I want to mention that the best thing you can do to get your food, your nutrients, is to get them from healthy food sources. There's certainly a role for supplements, but we hear a lot of advertisement about kind of magic pills for brain health. And in fact, there is no magic pill. It really comes down to healthy diet, emphasizing whole foods, and really less processed foods, but there's certainly times that supplements are appropriate. All right, great. Let's go on and talk about the CARE Toolkit. So this QR code will bring you to the CARE Toolkit, which is a free online toolkit that is available from the Gerontological Society of America. And just to give a shout out, we also have an obesity toolkit if you're interested in that space as well. So you can get that CARE toolkit. You can also just go to geron.org and you'll see CARE right up on the top. And so the CARE toolkit is built around this CARE framework. And so the CARE framework is really 4 steps. It starts with kickstart a brain health conversation. So in that kickstart, it's all about talking with patients or people about brain health and beginning a conversation about cognition. And the A is assess for cognitive impairment. And with that, we're doing some simple screening to say, is there a cognitive impairment? And then E is evaluate for dementia. and R is refer for community resources. So how this care framework came about was actually beginning back in 2013 when the Centers for Medicare and Medicaid Services approached the Gerontological Society of America and said, people really aren't using that annual wellness visit benefit that they have available to them through Medicare. And a big part of that is that they will have a routine cognitive screening. And someone mentioned this earlier, that starts at 65. So this group put out a report and recommendations, and in it was this care framework. And so GSA took that care framework and released the first care toolkit for brain health back in 2017. And it was a giant binder that had printed copies of everything you could ever want about, checking your brain status and things like that. And then from there, GSA updated that in 2020 to be a PDF, thinking about how much brain health, talking about brain health and talking about obesity have a lot in common, particularly when someone's an older adult. Nobody really wants to talk about either of these subjects. There's a lot of stigma around both topics. And there's kind of a feeling, well, why bother? What are we going to do anyway? So GSA launched this care toolkit for obesity in 2022 around this similar framework, same framework, a little bit similar adaptation. Then in 2024, we launched the IDDD Companion, a web-based brain health toolkit, and we have since actually just launched a web-based obesity kit as well. So this is an evolving kind of line of products that all really are focused primarily at primary care, but they do offer a lot of resources regardless of where you sit in kind of someone's care continuum to help anybody at any stage, any place along that continuum. So what about this care toolkit? It is fully online, pretty user-friendly. We're actually doing some work to even enhance the user-friendliness of it. There's 4 main sections of that that align with those 4 steps of the care framework. However, there's also a section on practice management and some other sections and other resources there as well. Each section includes key takeaways, and I'm going to share those key takeaways with you. And then there is an increased focus on brain health promotion. The difference in the science from when CARE started in 2015 until where we are now in 2026 on how much we know about brain health promotion is really remarkable, and we continue to learn more. This toolkit isn't all GSA stuff. It's a compilation of the best that's out there. So evidence-based tools and resources that are available to providers, and then experts guide ongoing updates and enhancements of the toolkit. And so let's start with Kickstart. And in Kickstart, it's all about increasing awareness of how important brain health is, that we actually can do things to help promote our brain health. And we're all about beginning to have that conversation where we can hopefully detect signs and symptoms of brain health concerns that might lead to further evaluation. So this is really normalizing the conversation and getting that conversation started. And so what are our tools and strategies in this? The strategies here include raising the topic of brain health, educating the people about modifiable risk factors and strategies to support brain health, asking individuals about their memory and cognition, listening for their concerns, whether the patient or the family expresses them, addressing sensory loss, and also using communication strategies that are appropriate for the individual. I remember one story, a colleague told me her dad was in the emergency room and the doctor said, your dad has profound dementia. And she said, my father cannot hear a thing you are saying, because they weren't communicating effectively and he didn't have his hearing aids in the emergency room. Alerting and teaching members of the team to observe for cognitive impairment. I think that, as I mentioned before, everybody has a role in this. If it's someone who's a receptionist or someone who's maybe supporting a person through Meals on Wheels or in the dentist office or something like that, everybody's got the opportunity to be aware of this. And then recognizing the different diverse life experiences of everyone and how they kind of play into this. So in each section here, I'm going to give you a little tour through the CARE toolkit, and I invite you to follow along if you've used that QR code. But this is really the home page of the CARE toolkit, and if we were to click on Kickstart, it's going to take us in there at the beginning. At the top of each page, you're going to see a little video that is really a wonderful story of patients, of people living with dementia, of their care partners, their spouses, and a bunch of clinicians talking about each step of the CARE toolkit. So I encourage you to watch those, and we're actually going to watch a couple of clips of those today. And then on the bottom of each of these kind of home pages for each section, you're going to have opportunities to click on these different tiles. And the one we're going to click on is engage in conversations about protective action. And here you would get to information about preserving brain health. So it's lots of strategies based on the new research where you can learn a little bit about how you can protect your brain. Again, a lot of those 10 strategies we just looked through. And on the, oops, I went too fast. I think I might have to stop sharing quickly and then reshare with my sound. So let me just do that real quick. Okay, sorry about that. I am going to hopefully play you a little clip of a video.
Primary care physician just ask the question, do you have any concerns about your brain health?
I would tell a doctor to ask the question. Ask your patients. It's a gift you're giving them, an opportunity to speak something that's probably in the back of their mind if there's an issue.
These questions aren't diagnostic tools, they're just conversation starters. They let your patients know that it's safe and appropriate to talk about cognitive changes without fear or shame. If their answer is no, I haven't noticed anything, you've still planted a seed. You've let your patient know that you are paying attention to their brain health, that it's part of your care, and that they can bring it up later if something changes. You can also normalize the conversation by framing it as part of healthy aging. Say something like, as we age, it's normal to keep an eye on how our brain's doing, just like how we watch our joints, our eyes, or our heart.
It's destigmatizing to say, I bring this up for every person every year. This is just a part of our functioning in health. I just want to ask how things are going.
And the more that we bring it up and the more that we normalize it, it can take a lot of stigma away. Most people, not just people living with dementia, get their health care at primary care. It's like the front door to the whole healthcare system.
Hey, can somebody give me a thumbs up if you could hear, or a thumbs down if I need to turn it up?
Sounded good to me, Jen.
Great. Okay. Very good. All right. Well, let's go on to the A section, the assess for cognitive impairment. So here it's all about detecting cognitive impairment and deciding if someone needs a diagnostic evaluation. So how do we do that? We used validated brief test to assess for cognitive impairment. We use standardized ways to capture information from the individual and from their families, friends, whoever might be accompanying them. And so here we go to brief cognitive tests. And if we click on that, we will see all about using those tests, including factors to consider. And I know you all use the AD8, and I want to mention that that is not included in the CARE toolkit. Our experts who guided us chose certain ones to include there. But it is the tool that you all are required to use as the screener for people in this system, the IDDD system there in Ohio, for anyone that's over the age of 18. And I do want to point out to you that there's a case study here, and this is about medical assistants administering the mini-cog. So one of the things I heard about is that often I saw in your chat that often providers don't talk about cognition or don't check for cognition because they don't have time. The bottom line is it doesn't have to be a physician or a nurse practitioner or a physician assistant. This study that I'm clicking on here shows you that in fact medical assistants were trained to use the mini-cog. Just as all of you, we have sorry about that, SSAs in Ohio doing the AD8. you can be confident with appropriate training that you do have the skills to do that work. And that what you're doing there is a meaningful step to help identify impaired cognition for people. So this case study, and actually I recently talked to a doctor up in upstate New York who's actually trained 7 county offices for the aging for their workers to do the mini cog and then refer them to a memory, to have further testing if they actually do find some issues. So it is feasible and it is valuable. So I just want to reinforce that with all of you. So let's take another little look.
Toolkit smoothly. After you've kick-started normalizing the topic, you can introduce the assessment test naturally. We're keeping an eye on your brain health today. I'd like to do a quick memory test and thinking check. It should only take a few minutes. You can use clinical staff such as medical assistants or nurses who've received the training to administer the test early in the visit, including the results in the medical record.
All right. I am just going to take one quick second here to turn my sound up a little. Actually, I'm not. Okay. All right. And next we're on to evaluating for dementia. And this is where we highlight the importance of a diagnostic evaluation. We rule out reversible causes for impaired cognition. And then we conduct a diagnostic evaluation. And this is the section where I want to just briefly tell you the story that led to the development of the CARE toolkit, a companion for for people with intellectual and developmental disabilities. I was talking with one of my nurse practitioner colleagues. I'm not a nurse practitioner, I'm a registered nurse, but she's a nurse practitioner. And she told me the story of a man who had lived in a large institution for his whole life and had an intellectual disability. And he was moved to a community group home. And when the group home called the provider and let him know he was having some changes in his activities of daily living and his cognition, he was diagnosed with dementia over the phone because he had Down syndrome and he was of a certain age. In fact, when my nurse practitioner friend saw him, he was profoundly depressed. And we all think, oh, isn't that great? He moved to a new place. It's a nice community setting, but he had lived in this large institution his whole life. Everything he knew from his routine was there and his friends were there. And so as a nurse, I thought, how can that be happening that someone is not getting evaluated at all? And so regardless if someone's part of the general population or whether someone lives with an intellectual or developmental disability, there's clear steps we can take to look through and say, is what's going on here a change that is actually treatable or reversible? And so how do we do that? We start by explaining why this diagnostic process is important. What does it entail and why is it important? And then we go through this diagnostic process. Now, sometimes primary care will refer to a specialist, but that's certainly not necessary. But primary care, even if they do refer to a specialist, can own a lot of this stuff to figure out some reversible causes before they get to a neurologist. And then if we do say, yes, this person does have dementia, we want to figure out the cause of that dementia, appropriately document the diagnosis, and then disclose the diagnosis to the individual and who else may need to know based on that person's life. And then just to point out one section here, components of a diagnostic evaluation. This section, and this shows our top of the page where currently we list 8 recommended components. This is a section of the MDS that is the CARE toolkit that is under construction. There are, though, what we talk about now is 8 recommended components. And you can see we're going to do a medical history, cognitive and mental status testing, looking at function, doing a thorough exam, potentially neuropsychological testing, lab tests, neuroimaging, and we may refer to a specialist. And if we refer to a specialist, we actually mention some things in the CARE toolkit that are suggestions when someone may refer to the specialist. And then we have what we call a practice pearl. And you'll see these throughout the CARE toolkit, where if you click on them, you'll get a little pop-up that will tell you some information from that individual clinician. You can see it's Fred Ketchum, Dr. Fred Ketchum from out in Wisconsin, who is a neurologist, has given us this practice pearl. How do you get someone to neurology that makes it an effective referral for them? And so in this case, they've already addressed those non-neurological components. There's that giving that referring provider the reason that you're sending them, and then strengthening that relationship with the doc to really have that that kind of two-way street of conversation. So you'll see these practice pearls and little case studies sprinkled throughout the CARE toolkit. So let's talk about evaluate. Let's see the providers talk about it.
In the CARE toolkit for brain health, evaluate means that if cognitive impairment is detected, you either conduct or refer for a diagnostic evaluation. Positive screen triggers the need for timely diagnostic follow-up. Is this a type of dementia, depression, sleep issue, a medication side effect? We owe it to our patients to find out.
We knew all along, we knew something was going on, whatever you formally label the condition. When we got the phone call, when the nurse called us and said, yes, there is some brain atrophy and the diagnosis is Alzheimer's, however she worded it, from that moment forward, it felt different. I mean, it was like any horrible diagnosis of a disease, I guess. It just felt different from that moment forward. I mean, we knew it, we saw it, but when they label it, it was real.
Okay, so let's chat here a little bit. I mentioned identifying reversible causes of cognitive impairment. So I want to just have you use the chat and think about what are some potential reversible causes of cognitive impairment. Go ahead and use the chat. Infection, UTI, stress, medication side effects, dehydration, sleep issues, illness, concussion, thyroid issues, diabetes, depression. You guys, I think, got just about everything on my list. Great job. Pneumonia, certainly. Any kind of infection. I can remember my days as a nursing home nurse. Someone would come to me and say, that resident, they'd say their name, is just not right today. And usually the first thing the nurse in that situation says is, does their pee stink and have they moved their bowels today, right? Because the first thing we think of is UTI, or are they constipated or something else going on. So it's always thinking about those reversible causes. So great job. And then the fourth step is referring for community resources. So think about in your case as someone who works in the ID or DD system, you probably have peers who work in the kind of offices for the aging or a similar. And actually, one time in Ohio, I had the pleasure of training both of those groups together. And it was kind of cool. It was the first time that those groups had been brought together. I think about myself, having spent my life in the older adult space. When I had the opportunity to go to the OACB conference a few years ago, I was so impressed with the technology that's used in this space where you all work, and how technology is used to really enable people to be as independent as possible. So really cool, and I think we have the opportunity to really learn from each other and talk about what community resources are out there to support people as they age or as they become potentially living with dementia or Alzheimer's. So how do we then support them and provide that ongoing support and education as well? And so this section is all about referring to providers, resources, and services, keeping in mind that when we say referring to others, we don't mean that the primary care doctor isn't still the hub, hopefully managing all of that, but recognizing that there's other services, whether they're internal or external, that can be helpful. Providing continuous education, keeping in mind that for caregivers and for people living with dementia, the needs differ as the course continues, and then when appropriate, referring for clinical trials. And so in the refer section, we're going to just click on culturally informed care there, and that will get us to really looking at what are those culturally informed conversations. And we provide some suggested approaches for potentially how we can improve care for people with dementia with differing backgrounds. So lots of different resources in here. And let's just take a quick listen to our video.
Diagnosis on its own isn't going to equip the caregiver. It's not going to empower the person that's living with dementia. We need resources. We need support.
They often feel like they are in a maze and it's dark. They cannot find their way out and they are by themselves, completely alone. In primary care, you have the opportunity to take them by the hand, turn on the light, and show them the way out. And it will absolutely make a lifetime of difference for them in this most vulnerable time.
The CARE Toolkit reminds us that our job isn't done until patients and families are connected to qualified services that can help meet those needs. Here's how you can implement refer in your practice in a practical, patient-focused way. First, establish a standardized referral process. Whether your clinic has internal help like care managers or social workers, or you rely on external community agencies, a structured process ensures consistency. You want to be able to say, here's what comes next, and here's who will help. For example, a clinic-based care manager can determine where a patient is in terms of safety at home, stress levels of caregivers, or access to healthy meals.
Okay. And now we have the CARE Toolkit Companion. So this is a companion document. It is a PDF document. I have two QR codes. The one on the left is a direct download and the other is a scrollable version. So if you click on the direct download, it is actually going to open up immediately on your device. And so you certainly could save it that way. I'm sure one of my colleagues will put it in the chat for you all too. Again, or you can use that scrollable version. But let's take a quick tour through this. So why did we do this? And I already told you my story as to the personal thing that I heard that I thought we have to do better. But really the goals of this companion document are to raise awareness of unique needs of people living with intellectual and developmental disability, equipping and encouraging caregivers and healthcare teams to engage in appropriate brain health conversations with adults with intellectual or developmental disabilities, promote brain health conversations and early detection and changes in cognition and adaptive function for adults with IDD, and then assisting with the identification of community supports and resource networks aimed at enhancing function and quality of life for adults with dementia and intellectual disabilities. And so just have some kind of highlighting some different tables and resources, or at least clips of those. And in the early part of this toolkit, there is something that I think is really a cool resource that is a summary of characteristics in adults with IDD or other neurotypical conditions compared with the general population. So you'll see here someone who has the autism spectrum disorder. They have potentially slightly higher risk for dementia. The dementia type that's most common would be frontotemporal. What are some key risk factors or features? What are causal features if it's known? And then what are associated features? So for this, be variability in communication abilities or loss of prior function without other explanation. So I think this is one of the most useful tools in the whole companion document. And again, you can find that the first table in that document. Okay. And so in the Kickstart, we have some key concepts. And in this section, I'll just review these key concepts with you. And so here we're looking at when we're communicating with older adults, we need to use these strategies in language that the individual is able to comprehend, but also to the extent possible, incorporate caregivers in conversations and really, use them as informants, but also as interpreters. And then thinking about using the strategies, I said strategies and language. Okay. When we're talking about cognition and really assessing cognition for an individual with intellectual and developmental disabilities, the whole piece of this falls back to baseline. What is the baseline for that individual? So what is the first determining their optimal level of function and then maintaining kind of that record of function and behavior over time? And one way to do that is to compile what we call a life story. And this can be really an important resource for talking with providers where caregivers can create that baseline, potentially just with our phones, a video diary that includes recordings of them speaking, interacting with others, performing various activities of daily living, looking at fine and gross motor skills, and then engaging with other activities that reflect abilities, talents, and uniqueness of that individual. And that archive can be really invaluable for determining future changes in function. And of course, healthcare providers and all of us, we hope, are using disability inclusive, person-centered, person-first language. Okay, and then I think this is a very, very important point in our key concepts of assess, and that is perhaps one of the biggest barriers I think that people with individuals with intellectual and developmental disabilities and their caregivers may face is this idea that manifestations of new cognitive impairments or dementia may automatically be assumed to be symptoms of their underlying disability. We think of this as diagnostic overshadowing, this idea that everything is inappropriately attributed to that underlying disability. It's really important, and you all know this far better than I do, that it's so important that we adapt assessment tools to accommodate any sensory issues, and that we do use this idea of longitudinal assessment. So we've used that baseline, we've established that baseline functioning for that individual, maybe with that life story, with that video, and then we look at how does that change over time. And again, capturing that individual's history is really that important first step. And then we use cognitive assessments. I think somebody already mentioned the NTG assessment. So using tools that are specifically developed for individuals with intellectual and developmental disabilities. In general, assessments of cognitive function are typically based more on population norms. Thus, in many cases, they're not appropriate for individuals with intellectual and developmental disabilities. But we do, in this section of the toolkit, offer some really nice recommendations for assessment of people with intellectual and developmental disabilities. What are some general measures? What's the frequency that you might want to measure that for impaired cognition? How might you need to adapt those tools? What are barriers, and how important are informants in that process? And then our evaluate. So think about dementia often as a diagnosis of exclusion. In other words, if we see a functional decline in an individual, it's through that thorough evaluation where we're able to determine if a diagnosis of dementia is appropriate. So we're looking at all of those things that are potentially reversible causes that you all just chatted in a little bit ago, where we're looking at, we've had this change in function or behavior. Is it due to other illnesses? Is it a medication side effect? Is it physical or sensory issues? Is it nutritional issues? Vision or hearing changes? Or are there adverse or disruptive life events? That example where the older adult or the person with intellectual developmental disabilities moved, lost a family member, something along those lines. And it's really important, again, that I mentioned that idea of diagnostic overshadowing, that we're avoiding that. We aren't just saying, hey, this is what we expect. They have this condition. We expect they're going to decline as they get older. That shouldn't be considered the norm. Rather, we should identify these, all of those conditions that I just mentioned that may be amenable to treatment to help reverse the changes in function or cognition. And then again, that thorough exam cognitive assessment, as well as looking at a variety of issues as part of that thorough evaluation. And then if we determine they have dementia, what is the dementia stage? And determining that can really be important in helping develop a dementia care plan, as well as recommending post-diagnostic supports. And so there is a really nice table that is conditions that may cause memory changes in adults with intellectual disabilities. And again, it just gives lots of things to consider here, whether they're sleep problems, mobility problems, psychosocial or environmental stressors. And then we do have the components of a diagnostic evaluation as well. And I want to mention here that these tables and things shouldn't necessarily be used in isolation. The whole idea is that everything within this toolkit is used as an adjunct to what's in that main care toolkit. So the two really belong together. And then we do have the examples of the dementia screening tools. And certainly that NTG tool is listed in this table. This is really a nice table that gives the strength and weaknesses of the tools, as well as a brief description of them. Excuse me. And then we have the refer concepts. So what do we have in refer in this companion? So if we actually have that diagnosis of dementia, referring to resources in the community helps that adult with dementia and their caregivers receive that appropriate post-diagnostic supports and services. And certainly the state developmental disability agencies, and you're providing that case management and really being that critical link to these other supports and services that might be out there. We're going to share the diagnosis as appropriate with other entities that may be involved in care. And really, we're adapting care approaches that are used for the general public for the individual that has the intellectual or developmental disability and dementia. And then remembering that this caregiving, is a process that continues to change over time. So these plans are going to evolve as their dementia potentially progresses, or as other pre-existing diagnoses change as they continue to age. And there are some suggestions around post-diagnostic supports for adults with intellectual and developmental disabilities. And we're really adjusting, a big part of it, really adjusting activities and care practicing to make sure that they continue to have that person-centered care. And we really look at this by stage as well in this chart. And then we do have strategies for managing dementia as well. So managing different signs and symptoms and how we might be able to react to those new signs or symptoms is in this refer section as well. And so before we close and really open it up to you all's questions, I have two more questions for you. The first is, how can you use these resources that I've shared with you today to help those people that you serve? And go ahead and use the chat for that. Chat in for us. How can you use these resources to help the people that you serve? Use them to advocate. Share them with providers and SSAs. Share them with team members. Open the conversation on brain health. Educate family members. Share the information. Recognize concerns earlier. Empower providers and families to discuss with their medical team. I had someone in Ohio say, I'm taking this to see my doctor when I go. They never ask me about my brain. Start talking about this. Lessen the stigma. Explain the information and resources. There's so many resources out there for people in the general population, for people in all different populations, with all different backgrounds and things. So just share those great resources and use the toolkit to help them. Great. Focusing on this and providing resources to individuals, providers, and families. I have a question here. Melissa, I'm going to ask you to put that question in the Q&A so we can answer that when we get to that section. And then finally, I want to ask one final question, and that is, what did you learn that can help you or your loved ones? Is there something you learned that can help your brain health, or that you're going to share with your family or share with your children or your best friends? to not shy away from conversations of brain health. Fantastic resources of brain health online. The Mind Diet. I'm ordering the book. All right. It's worth the conversation. Work on my brain health. What's one little thing you might do after today different to work on your brain health? Oh, you learned about what's normal, forgetfulness, and abnormal. Keep my brain engaged with new hobbies. Walk more. Someone's going to share this information with their care team. Diet and exercise. Getting your hearing checked. Hearing is such an important risk factor. It's not listed in the things that we do. Lessen screen time or put down the screen time before bed. More veggies. Keep moving. Learn more about the Mind Diet. Excellent. You guys have paid attention. I can't wait to see when you do your post test how different they are from when you started. And so with that, I want to say thank you so much. I am going to just give one more slide here that has my email, that has a QR QR code to the Care Toolkit. And also, if you go to geron.org/brain health, you will get all of our free brain health resources. Everything that I do in my division at GSA is free. I just want you guys to take that stuff and use it. And I'm going to close with Michelle's last comment that says, brain health is important, just like checking on other parts of your body. No doubt about it. We need to check our brain health and keep an eye on that as well.